Welcome to the deep dive. Imagine surviving a grueling, life-saving stem cell transplant.
Right, which is an incredible feat on its own.
Exactly. I mean, you endure the conditioning, you weather the intense recovery, and you finally reach remission.
The ultimate goal.
Yeah, but then, months or maybe even years later, you discover that your own body is quietly replacing healthy, vital tissue with rigid scars.
It's a terrifying reality for a lot of survivors.
It really is. And today, our mission is to answer a highly specific, critically important medical question. Can chronic graft-versus-host disease, or GVHD, cause vaginal mucosal dryness?
It is such a profound question, honestly. It exists right at the intersection of oncology, immunology, and gynecology.
Yeah, it covers so much ground.
It really does. And for you listening, whether you're a clinician navigating these disciplines or just someone interested in the long-term realities of survivorship, this is a topic that demands our attention. And to get a comprehensive picture, we're synthesizing a big stack of highly specialized sources today. We are pulling from patient guides from Anthony Nolan, the NMDP, and BMT Infonet.
We've got a lot of ground to cover.
Yeah, and we're also analyzing clinical frameworks from the Royal College of Obstetricians and Gynecologists, alongside guidelines from the NSSG.
But, we aren't just going to hit you with a simple yes and move on.
No, definitely not.
We are going to explore the fascinating, sometimes devastating biology behind why this happens, like why it's so dangerously underreported.
Right, affecting anywhere from 24 to 69% of female patients.
Which is wild.
Yeah.
And we'll talk about how modern medicine is fighting back. Okay, let's unpack this. Before we can even understand the specific symptom of vaginal dryness, we have to look at the systemic phenomenon of GVHD.
Right, so the foundational mechanism of GVHD involves a profound biological misunderstanding, essentially.
A misunderstanding.
Yeah, because during an allogeneic transplant, the patient receives donated immune cells, which is the graft.
And the goal there is the graft versus tumor effect. Right?
Exactly. You want those new immune cells to hunt down any lingering cancer cells.
But something goes wrong.
Right. The complication arises when the donor's T cells start surveying their new environment, because despite careful matching, there are always minor differences.
So the graft doesn't recognize the host.
Exactly. The newly donated T cells recognize the host's own tissue as foreign, and they mount the sustained T cell-mediated immune response against the patient's own body.
I always picture it like hiring a highly trained, aggressive new security team for a corporate building.
Oh, I like that.
Right. So you bring them in to neutralize a specific threat, the cancer. But the security team doesn't have the original blueprints for the building.
They don't know the layout.
Exactly. They don't recognize the foundational architecture. So instead of just patrolling the hallways, they assume the building itself is the threat.
Wow, yeah.
They just lock the doors and start tearing up the lobby, smashing the drywall, destroying the infrastructure.
That analogy actually holds up incredibly well when you consider where those T cells tend to congregate.
Where do they go?
Well, they're naturally drawn to barrier tissues, the doors and windows of your building analogy.
Right.
So we frequently see chronic GVHD manifesting in the skin, the gut, the lungs, but the genital mucosa is a prime target because it is a highly immunologically active barrier.
That makes total sense.
And our sources note that this isn't an immediate reaction. We are looking at chronic GVHD, which typically begins to manifest late in the first year post-transplant.
Or even 1 to 3 years out, right?
Yeah, exactly. It takes time to develop.
So that sets the tearing up the barrier tissues. But pulling that back to our core question, how does that systemic immune attack directly cause vaginal mucosal dryness?
Well, to answer the question directly, yes. Chronic GVHD absolutely causes vaginal mucosal dryness.
But it's not just like normal dryness.
Not at all. The underlying cellular reality is what you really need to understand. When those donor T cells infiltrate the vaginal mucosa, they release inflammatory cytokines.
Which causes massive inflammation.
Intense, localized inflammation, yes. Patients experience profound dryness, but it goes far beyond simple dehydration.
The sources describe it as feeling gritty, right?
Yeah, intensely gritty, accompanied by severe burning and persistent itching. And visually, clinicians might observe white lines inside the vagina.
Like lichen planus.
Very similar to lichen planus, yeah, alongside mucosal fissures and contact bleeding.
Just listening to those symptoms, I mean, the grittiness, the fissures, the burning, it's clear this isn't just an immune attack operating in a vacuum.
No, it's a much bigger problem.
The sources call this a double whammy effect. Because the dryness isn't just from the T cell attack, It's compounded by something else entirely.
What's fascinating here is how those two distinct biological events compound each other at the cellular level.
The double whammy.
Exactly. The dryness and atrophy are severely exacerbated by iatrogenic menopause.
Medically induced menopause.
Right. The pre-transplant conditioning regimens, like total body irradiation or intense chemo, they are inherently toxic to rapidly dividing cells.
And the collateral damage there is the ovaries,
Yes, the complete destruction of the ovarian follicles.
which instantly plunges the patient into a severe, permanent hypoestrogenic state, a complete lack of estrogen.
And from a purely physiological standpoint, estrogen is the primary architect of healthy vaginal tissue.
It keeps everything functioning.
Yeah, it stimulates the epithelial cells to produce glycogen. That glycogen feeds the local lactobacilli, which maintain the acidic pH and keep the tissue plump and elastic.
So you take that estrogen away abruptly, and the entire ecosystem just collapses.
Completely collapses. The epithelial layer thins out, natural lubrication stops, and the tissue becomes highly fragile.
And that's the baseline state before the GVHD even sets in.
Right. That's the state of the tissue when the T cells arrive.
So you have a mucosal barrier that is already starving, brittle, structurally compromised. And then you unleash a targeted, cytokine-driven immune attack directly onto it.
It is the ultimate hostile environment for mucosal health. The iatrogenic menopause removes all the natural defenses, making the tissue exponentially more vulnerable to the inflammation.
That dual mechanism really explains why it's so profound and so hard to treat.
Exactly. It's much more complicated than standard age-related menopause.
Okay, looking at the severity of this, I have to bring up a massive contradiction in the data.
What's that?
If this biological double whammy is a known consequence of these transplants, why is there such a pervasive silence around it?
It is incredibly underreported.
I mean, I'm looking at the statistics from Dr. Oluwatosin-Goshe's presentation in our sources. She highlights that it's estimated to affect between 24 and 69% of female patients.
Up to 69%.
That is a staggering majority of patients experiencing a highly destructive complication, yet it's called a silent struggle. Why is no one talking about it?
Well, the underreporting stems from a perfect storm of diagnostic confusion and just the siloed nature of modern medicine.
Diagnostic confusion,
Yeah.
like patients mistaking it for something else.
Yeah, from the patient's perspective, there is significant symptom overlap. If you are experiencing dryness and itching after a transplant, you might just assume it's standard early menopause from the chemo.
Oh, sure, or because you're immunosuppressed, you might assume it's just a routine yeast infection.
Exactly. Opportunistic infections are common post-transplant. A patient might try an over-the-counter antifungal, find no relief, and just kind of resign themselves to the discomfort.
But the clinical literature also explicitly points out that patients just won't report these symptoms unless a physician directly asks them.
They really won't. It's an intimate, sensitive issue.
I have to offer a pushback here, though, on how this is handled clinically. If the medical community knows that up to 69% of female recipients might develop this, why is the burden on the patient to report it?
It's a huge systemic issue.
Right. I mean, proactive screening should be an automatic part of survivorship care.
That is the exact friction point specialists are trying to correct right now. Post-transplant care is incredibly complex and hyper-focused on the primary disease.
They just want to make sure the cancer doesn't come back.
Exactly. The oncology team is laser-focused on tracking blood counts and monitoring remission. Gynecological health easily falls into the blind spots.
So the oncologist assumes the patient will raise a flag if there's a problem.
And the patient assumes the doctor would be actively monitoring it if it were a standard complication. It's a terrible miscommunication loop.
And while that loop plays out, the psychosocial impact is just devastating.
Truly devastating.
The sources stress that this causes distorted body image, severe anxiety, depression, and a deep feeling of inadequacy with partners.
It alters a person's fundamental quality of life. You endure the trauma of blood cancer, the extreme conditioning, the transplant itself, only to feel like your body is permanently damaged in this highly intimate way.
It's so unfair.
It is, and the embarrassment and psychological weight of that just keep the silence intact.
But the reality is, maintaining that silence doesn't just mean living with discomfort. This leads directly into the stakes of the situation.
The physical stakes.
Yeah. What happens to the local anatomy when this inflammation is left completely unchecked?
If we connect this to the bigger picture, we have to fundamentally reframe how we view vaginal dryness. It is not merely a comfort issue.
It's a structural issue, right?
It is a critical structural threat. When chronic inflammation persists over time, the body's natural response is to try to heal the damage by laying down collagen.
Which is fibrosis.
Yes, it actively replaces soft, pliable mucosal tissue with rigid, inflexible scar tissue.
So the normal stretchy vaginal canal just stiffens.
It stiffens, it narrows, and it loses its elasticity entirely. This is called vaginal stenosis.
Oh, wow.
And in more severe cases, the inflammation strips the epithelial layers entirely, causing raw surfaces that eventually fuse together.
The fuse closed.
Yes, these dense adhesions are known as synechiae. Without intervention, the vaginal canal can experience complete obliteration.
It is permanently altering human anatomy.
It is an aggressive architectural remodeling, and the effects are severe. It inevitably leads to dyspareunia, making vaginal sex excruciatingly painful or entirely impossible.
And it affects menstruation too, doesn't it?
Yes, if a younger patient's ovarian function recovers, that dense scarring can obstruct the outflow of menstrual blood, creating a massive secondary crisis.
And our sources say it's not just the vaginal canal. The urethral area is at risk too.
Right, the chronic inflammation can lead to urethral strictures. The urethra narrows, making urination intensely painful and drastically increasing the risk of severe urinary tract infections.
The stakes are just incredibly high. We are talking about preventing irreversible destruction.
Exactly.
So how are specialists taking back control? If we know the mechanism is estrogen deprivation plus a T-cell attack, how do we reverse the scarring and manage this?
It fundamentally requires a shift to proactive clinical protocols. The absolute gold standard recommendation is proactive, scheduled screening.
Don't wait for symptoms.
Right. Women need a comprehensive gynecologic exam by a specialist familiar with transplants about 3 months post-transplant and annually after that.
Because the inflammation and estrogen starvation are brewing long before the tissue actually fuses together.
Early detection is paramount. And once identified, the management strategy has to address the double whammy directly. We must replenish the hormones and suppress the immune infiltration.
So attacking the iatrogenic menopause first, the sources talk about using topical estrogen.
Yes, localized estrogen.
Right, like a pill, a cream, or a ring. But why is it so critical that it's localized and not systemic hormone replacement therapy?
Well, many of these patients have complex oncological histories. Introducing systemic HRT, which goes through the entire bloodstream, might carry unnecessary risks.
The topical keeps it isolated.
Exactly. Clinicians deliver the hormone directly to the vaginal tissue, which rapidly restores thickness and lowers the pH without systemic exposure.
But the estrogen alone doesn't call off our rogue security team. It repairs the walls, but the T cells are still attacking.
Right. To neutralize the immune response, specialists deploy high-potency topical steroids, like clobetasol propionate.
Or immunosuppressants, right.
Yes. For long-term maintenance, they use topical calcineurin inhibitors, like tacrolimus or cyclosporine. These agents shut down the T-cell activation right at the mucosal site.
Okay, here's where it gets really interesting. To combat the profound dryness and repair the skin barrier, the sources mention a specialized moisturizer.
Yes, it's brilliant.
They're using formulations of vitamin E compounded with hyaluronic acid. If you follow skincare science, you know hyaluronic acid holds vast amounts of moisture.
It binds water molecules perfectly.
Right, and they combine it with vitamin E, which is an antioxidant, to actively reconstruct the mucosal barrier from the outside in. Medicine is borrowing from skincare to treat internal tissue.
It illustrates how targeted this management must be. But pharmacological intervention is only one facet. Patients also need mechanical therapies to prevent fibrosis.
Like vaginal dilators.
Yes, graduated dilators stretch the mucosa, preventing synechia and stimulating blood flow. And this is often paired with pelvic floor physical therapy.
Before we wrap this all up, there is a specific myth from the sources we need to bust.
This is a very important one.
Given the physical presentation, the white lines, the fissures, the pain, patients often harbor a terrifying fear that this is contagious.
Because it visually shares similarities with severe viral outbreaks or STIs. But the guidelines are absolute on this. Genital GVHD is unequivocally non-contagious.
You cannot spread it.
It cannot be transmitted through sexual contact. It is an internal, sterile, localized, autoimmune-like mechanism from the transplant.
So what does this all mean? We started with a specific question about vaginal dryness and uncovered a complex story of immune betrayal and a hormonal crash.
And we confronted the dangers of medical silence, where up to 69% of patients suffer from something that can completely obliterate their anatomy.
But we also mapped out the proactive therapies used to reclaim quality of life. The localized estrogens, the immunosuppressants, the hyaluronic acid.
All of which underscores the most critical takeaway for you as a listener. Whether you're a patient or an advocate, proactive self-advocacy is non-negotiable.
You have to speak up. The embarrassing symptoms are the most vital ones to discuss. Do not wait for a doctor to initiate the screening.
Absolutely. But I want to end with a lingering, provocative thought from the literature. We've focused on adult women, but genital GVHD can and does manifest in pediatric patients who have had stem cell transplants.
Wait, really? In children?
Yes, and it demands that we ask, how must pediatric oncology evolve?
Yeah.
How do we ethically and proactively monitor for such a deeply private, architecturally destructive side effect in young cancer survivors?
Without causing them further trauma during their developmental years.
Exactly. As survival rates improve, it is a complex, heavy question the medical community must urgently address.
It forces us to realize that surviving the cancer is only the first hurdle. But by challenging clinical silos and demanding proactive care, that's how we start to clear the picture.